Hello, my name is Elaine Husney. I'm a rheumatologist at the Cleveland Clinic. I have the distinct pleasure today to introduce Dr. Richard Ransohoff, who is a wonderful neurologist who I have consulted many times on hospital rounds, and he's also a world-class clinical scientist. Dr. Ransohoff is the director for the Center of Neuroinflammation Research at the Cleveland Clinic. He has lectured all over the world and has been a leader in neuroinflammation. We are lucky enough today to have him synthesize the topic of inflammatory cell trafficking across the blood-brain barrier as it relates to autoimmune diseases as well. He will be using a case example of multiple sclerosis to help us better understand the strategies used in targeting T-cell trafficking. Thank you, Dr. Ransohoff, for being with us today.
Thanks for the introduction and welcome to this morning's conference. I want to start with our learning objectives. What we want to do today is focus on how T-cell mediated immune responses take place in the nervous system, and particularly how trafficking is involved. And then at the very end, we're going to expand that subject out to describe how it is involved in other diseases. So we're going to take a broad look at T-cell trafficking during immune responses. So the first objective is to recognize the role of T-lymphocyte trafficking in immune responses. Then we want to describe the biology of MS and understand how lymphocyte trafficking is involved in that disease, because the central nervous system is somewhat different from the rest of the body when it comes to regulation of immune responses. Then we're going to talk about the strategies for targeting T-cell trafficking using the current drugs, which are natalizumab and fingolimod, as well as future agents. And then, as I mentioned at the end, I want to talk a little bit about T-cell trafficking to other organs as may be involved in inflammatory bowel disease, rheumatoid arthritis, and psoriasis. So let's go ahead and get started. First of all, I just want to take a step back and have a broad overview looking at the entire body. At the upper right, you see that naive lymphocytes enter lymph nodes from the blood. So those cells are coursing down that red arrow and back up the yellow arrow to the heart continuously. Naive lymphocytes circulate through the blood system and in and out of lymph nodes continuously. So they go from the blood into the lymph node, and then those lymphocytes, along with the lymph, returns to blood by the thoracic duct, just as you learned in medical school. The reason that they go to the lymph node is because that's where any noxious substance, including bacteria, viruses, fungi, any other sort of invader, that's where those noxious substances are concentrated for exposure to the immune system. So as you see at the bottom, this person has a cut on their foot, and antigens, which are simply products of the bacteria that enter that breach in the skin, go to the lymph node along with the lymph and carried also there by cells that we'll talk about in a moment. And that's where the T cells learn that there is something wrong, that there is an infection, and they mobilize an immune response, which in fact will travel right back to the infected site and eliminate the pathogen. That's an overview of how the immune system works. And the first point that we want to make is that T cells are moving around continuously, first to look for problems in that lymph node, and then secondly, to travel to the infected peripheral tissue. So with that as a background, let's jump into a case of multiple sclerosis. This is the case history. A 32-year-old woman who is a college professor. She's married. She doesn't have children, but wants to start a family this year because she is now settled in her career. She has no other significant past medical history, and she comes to your office in July 2011. In March 2011, she had optic neuritis in the left eye. This is a painful disturbance of vision lasting weeks to months and often followed by a very good recovery. She certainly reported this to her doctor because it hurts and affects vision. And her primary doc ordered an MRI brain scan because he knew that optic neuritis might be associated with brain disease and multiple sclerosis in particular. So she was waiting to get the MRI scan. The optic neuritis had gone away, and she had a spinal cord sensory symptom. That would be syndrome. That would be typically numbness from some level on the body downward. So, for example, from the umbilicus down to the feet. And this sensory syndrome lasted for 2 weeks and then went away. So here she is in your office, and it's July 2011. You perform a neurologic exam. That is normal, except that she has residual, mild visual disturbance in the left eye that was affected by the optic neuritis. You do a battery of blood work for things that can mimic MS, and particularly things that can cause an optic neuritis-like syndrome. So that would include things like sarcoid, lupus. You always test for B12 deficiency, and so forth. These things are all normal. The MRI brain scan that was done back in March, or a little bit after March, ordered by the primary care doc, is entirely consistent with multiple sclerosis and also has one ring-enhancing lesion, meaning that gadolinium shows up as enhancement in a ring conformation around the lesion. You make a diagnosis appropriately of clinically and radiographically active relapsing remitting MS, and it's appropriate to offer treatment. So you recommend that she begin disease-modifying therapy, or a DMA as we call it, and the most widely used one is interferon beta given by injection. It is appropriate to give the drug and monitor sometime in the first 6 to 12 months to make certain that the drug is working as you hoped it would. So after 6 to 12 months, you order an MRI brain scan, and that's shown on the next slide. What you see on the left is that first scan that you got in July 2011, and it shows a few lesions, particularly the ones near the midline are characteristic of MS. They are periventricular. And when you look at the new scan in February of 2012, you see at least 3 and probably 4 new lesions. Those are indicated by the arrows in panel B, and you find that disturbing, and that's going to launch our conversation. So now let's look at the disease, multiple sclerosis. Multiple sclerosis is the best example that we have of disease control or disease treatment by targeting leukocyte trafficking. What is MS? It involves inflammatory demyelination of the human central nervous system. One of the complexities of MS is it only affects the central nervous system. So blood tests are normal. Spinal fluid is abnormal, but is obviously only obtained by lumbar puncture, and in this case was not necessary. The onset is typically right around age 30. It can be anywhere from 20 to 40, but there's a fairly sharp peak of onset, say between 28 and 32, as with our case. The disease affects women predominantly. About 60 or some odd % of cases are women. There are about 2.5 million cases worldwide. The disease is caused by an interaction between genetics and environment and some other factors that are not very well understood. Because of recent genetic research, many of the genes that are involved in the susceptibility to MS have been identified, and these genes regulate the function of the T-cell limb of the immune response. The environmental factors have also been identified. The ones that are clearly established are Epstein-Barr virus infection, low levels of vitamin D, and cigarette smoking. The mechanism by which these are involved in causing MS is not clear. The natural history of disease without treatment is established by a number of studies that were done primarily in the 60s, 70s, and early part of the 80s. Effective treatment for MS was introduced first in 1993, so the natural history studies tell us what happens with no treatment. And frankly, it is a distressing disease. About 50% of individuals with MS will be using canes or walkers to ambulate after 20 years of disease. So this is a population of people approximately 50 years of age that are no longer walking independently. That's a considerable loss of function for these individuals. As I mentioned, treatments have been available since 1993. There are 5 main classes of treatments. Interferon beta, I've mentioned. Latirum acetate is another type of injectable treatment. Infusions of natalizumab can be given. Fingolimod is the first oral treatment. And cytotoxic immunosuppressives, such as mitoxantrone, have also been approved for the treatment of MS when it is quite severe. We will be discussing the mechanism of action of some of these drugs, so please don't be frustrated by the names. I should also mention that one of the reasons that this topic is particularly interesting for MS docs is because these drugs are not used widely in any other disease indications. So we're dealing with a somewhat new area of therapeutics here. The efficacy in individual patients ranges from excellent to negligible, meaning sometimes in some patients the medicines don't work at all. We have no biomarkers to tell us who is going to respond well to which medicine, and we need those rather urgently. Natalizumab, fingolimod, and interferon beta all at some levels target leukocyte trafficking, and that's the reason for this topic today. So let's look at what's special about the immune response in the central nervous system as compared with the rest of the body. This shows a basic science study in which killed bacteria were injected into the brain of a rat, and then the immune response was monitored by staining the tissue 2 weeks later. What you see in panel A is that there is a very, very wimpy inflammatory reaction, which is only seen near the needle track, and that's compared quantitatively in panel B with what you would see in the skin. That line that takes off and is sustained is what you see in the skin in the way of an inflammatory reaction, and what you see at the bottom, that line that just takes off and then drops off, that's the wimpy transient reaction in the CNS. So what does that tell us? Well, it tells us that the afferent system by which the brain tells the immune system something is wrong is both inefficient and slow, and therefore, if there is an immune response in the brain, it is typically going to be initiated in the periphery, meaning outside the brain, and then invade. So again, let's take a step back and look at how a generic immune response gets started and what it's composed of. In the upper left, where it says normal tissue surrounded by a green box, you see a cell there that has a peculiar shape. That's a specialized type of macrophage called a dendritic cell. It lives in that tissue and sits there and waits for something to go wrong. Something going wrong is shown in the upper right in the red box. That tissue is now inflamed. It's been invaded by a pathogen. And that pathogen will be engulfed by the dendritic cell, degraded down to very small peptides, and then exposed on the surface of the cell, conjugated to molecules that hold it up for T cells to find it. That cell will then use the afferent lymphatic, that kind of branch-like thing going into the central lymph node, and get into the lymph node where it will look for a T cell. The T cells come in by specialized venules called high endothelial venules, or HEV, in the upper middle. And if those T cells and antigen-presenting cells, dendritic cells, come together and the T cell finds the right antigen on the surface of that antigen-presenting cell, then the T cell will have a tremendous reaction. It will proliferate and throw off daughter cells that see exactly the same thing. Some of those will follow the route at the lower right and become effector cells, using the blood to get back to the inflamed tissue and kill the pathogen. And some of those cells will become long-lasting memory cells. You can see the blue box around the memory cell in the sort of middle left, and that cell can last for the lifetime of the individual. That's why after a single exposure to a virus, we may be immune to that virus for the rest of our lives, because that cell carries immunologic memory. Now, these antigen-presenting cells do three very important things for T cells. First of all, they tell the T cells what antigen is there. That's in the middle left. That little red ball is the antigen. And it is the yellow MHC molecule that holds it up for the T cell to see, and the T cell sees it using its T cell receptor. The antigen-presenting cell also gives survival and differentiation signals to the T cell, and we'll be talking about those in a bit. So once again, this is the generic type of immune response. If there's a breach in the skin, in this case in a mouse, then the antigen will be taken into the lymph node. The lymph node is the sort of golden oval there, and it will be carried there by dendritic cells. That's the cellular route, and that's the best way there is to initiate an immune response. Some of the material will float there in the lymph, and all of that material will gather in the lymph node, and that will initiate an immune response directed by the T cells that will go back to the skin and kill the pathogen. What is different in the CNS is that there is no cellular route for antigen to get into the lymph node. You can see the draining lymph node right by the mouse's ear, and you see that the yellow arrow is broken. There are no cells in the brain that can take up antigen and go to a lymph node and start an immune response, and that's why the CNS is called immune privileged. But we know it isn't totally immune privileged because there can be reactions in the CNS. Multiple sclerosis is an example, encephalitis is another. So how do we defeat this immune privilege? Well, if you put a little dab of bacteria in the brain by a careful injection, and then you immunize peripherally and look 2 weeks later, look at the difference between the left panel and the right panel. The right panel shows a violent immune reaction, and that's how you defeat the immune privilege of the CNS. What this means is that the efferent system by which the immune system finds something in the brain, once it knows it's anywhere in the body, if it's in the brain, the immune system will find it, and that tells us there is such a thing as immune surveillance of the central nervous system. So what does trafficking have to do with that? Here again is that memory cell. all memory cells have a kind of unique trafficking pattern by which they go from blood. You can see the venule on the left in the middle. They go into the tissues, look for any sort of pathogen. Then they use the afferent lymphatic and they scan the lymph node, and then they can go from the lymph node back into the blood. That is why trafficking is absolutely essential for immune surveillance and indeed for all immune reactions. So where in the CNS do you find this memory T cell? Do you find it in the brain? Do you find it in the spinal fluid or somewhere else? Well, we've been looking for that for a long time, and we finally found it in the spinal fluid. What you see here is a series of still photos from a movie showing a green T cell in the upper left and a red antigen-presenting cell in the spinal meninges of a living mouse. And a special type of photography was used to make these images, actually photomicroscopy. What you see is that the T cell in the middle upper panel extends a process, monitors the surface of the antigen-presenting cell. This is a healthy mouse, so it doesn't find anything, and it pulls back that process after a couple of seconds. In the middle panel, it goes to another antigen-presenting cell and sticks out another process, looks over the surface of that antigen-presenting cell, surveying all those MHC molecules for a bad antigen that should be reacted against. But it doesn't find anything, and you see that it becomes round in the lower middle panel, stays round in the lower right panel, and eventually will leave the picture. So by many years of research, both in humans and in mice, we came up with the idea that immune surveillance of the central nervous system is carried out by memory T cells, mostly CD4 positive T cells, in the spinal fluid. These enter the spinal fluid by traveling across the choroid plexus, where the spinal fluid is made, and they leave the spinal fluid area by the cribriform plate that sits under the frontal lobes and above the nasal mucosa. The cribriform plate is a heavily perforated and very, very thin bone where the olfactory nerves come into the brain. Where the olfactory nerves come in, there are these small openings, and the spinal fluid percolates out along with those T cells into the nasal mucosa, finding a afferent lymphatic and ending up in the deep cervical lymph nodes, right down in the bottom middle of this image. If you go back up to the upper right, you see that these T cells start in the blood. They go into the spinal fluid, which is the equivalent of tissue, and the equivalent of lymph. And after carrying out surveillance, they end up back in the lymph nodes and then return to the blood. So they have the correct trafficking pattern for immune surveillance T cells, and that's their job. So the spinal fluid is the equivalent of lymph for the central nervous system. Central nervous system has no lymphatics and no lymph, and instead it uses spinal fluid for that purpose. And that's another thing that's different about the central nervous system, and it helps us understand how trafficking is involved in both surveillance and in immune response, which is the next step if there's something wrong. So the brain is shown in the middle panel there, but in the upper right you see cells entering the spinal fluid. Those are memory cells to carry out surveillance. If they find something wrong, they mount an attack, and that attack will eventually cause enough inflammation to disturb the blood-brain barrier, and then effector cells will cross the blood-brain barrier along with activated monocytes. In the case of encephalitis, this is done for host response, and it's a good thing. In the case of multiple sclerosis, this is autoimmunity, and it's a bad thing. So the question then is, how do these cells find their way? How do white cells find their way around all the places in the body that they need to go? It turns out that there's a very simple, elegant, incredibly powerful mechanism, and this gives us the molecular targets that we use to treat leukocyte trafficking in diseases. As a general statement, all of leukocyte trafficking is controlled by molecular interactions that take place in a defined sequence between leukocytes and endothelial cells that line the blood vessels. Leukocytes pass through the blood at about 400 microns per second, very fast. However, if there is a patch of endothelium that is inflamed, and if the leukocyte has the correct molecules on its surface to recognize that inflammatory state of the endothelium, and those are called selectins, then the leukocyte will loosely tether to the endothelium. Now, it's interacting with the endothelium, and it slows down by about tenfold, but it's still being pushed by the blood, so it rolls along. If it finds a chemokine, a molecule stuck on the surface of the endothelium that can activate the leukocyte to be able to stick to the endothelium, then it will use integrins in the third panel and actually adhere. It'll stop, despite the fact that the blood is still flowing, and stick to that endothelial cell. And if it gets further traffic signals from the inflamed tissue under the endothelium, again in the form of chemokines, then it will find a way out of the vasculature. It will actually diapedese into the tissue. Let's take a closer look at this process. Here we're looking at the players in this process, and here you find the answer to the question, how can this single mechanism account for all of the leukocyte trafficking that we see in the body? And if you take a moment to think about it, you have these lymphocytes traveling in and out of lymph nodes and then going to infected tissue. You have neutrophils that enter sites of infection or of damage almost immediately. You have monocytes that come later in chronic inflammation. You have eosinophils that go to sites of parasitic infection or allergy and so forth. How can this all be accounted for by a single mechanism? And the answer is that a cell needs only one selectin, only one chemokine, and only one integrin to undergo the arrest that is preparatory to leaving the bloodstream. And so there turn out to be, if you look right under that sort of rolling leukocyte at the top left, there are about 5 different integrins. There are about 50 chemokines, and chemokine receptors number more than 20. And there are around 5 integrin combinations that can mediate this process. So if you take one from column A, one from column B, and one from column C, you can appreciate that you get many, many, many different combinations which can specify leukocyte trafficking everywhere in the body, including in the central nervous system. So what you see up at the top here is the leukocyte undergoing the rolling, activation, and arrest, and you see below all the categories and types of molecules that can mediate this process. When we talk about natalizumab, the drug for multiple sclerosis, it sees one and only one of these molecules, but it's an important one. It's the alpha-4 integrins, which mediate arrest. And alpha-4 integrins come in two flavors on leukocytes, alpha-4 beta-1, which goes to many inflamed tissues, but especially the central nervous system, and alpha-4 beta-7, which takes cells into the small intestine and other places in the gut. So natalizumab can be used for multiple sclerosis and has also been used successfully for Crohn's disease. Now, how do cells actually carry out this process? Here's an example of how leukocyte homing works. What you see at the top is three cells. One is a memory cell, one is a neutrophil, a polymorphonuclear leukocyte, or poly, and what you see on the right is the naive or virgin T cell, and we're talking about getting here into a lymph node. So how does this work? On the surface of the leukocyte, if you look first at the naive virgin T cell, the little triangles are selectins. The open triangles, or the open angles, are chemokine receptors. And the squiggly things, I think, are the integrins, yes. So the memory cell has no selectin to take it into a lymph node. So you can see that it doesn't even go through step one, it just passes through. The poly has the right selectins, but doesn't have the right chemokine receptor. So it may roll, but it will never be activated and stick. So a cell basically asks itself three different questions. Do I have the right selectin? Do I have the right chemokine receptor? Do I have the right integrin? And only if the answer is yes to all three does it actually home to that site. In this case, we're talking about going into a lymph node as a naive T cell, and only the naive virgin T cell can carry that out. So if we then look back at the nervous system, we see that there are molecular determinants, both for surveillance by T cells and for crossing the blood-brain barrier. The one that is held in common is alpha-4 beta-1 integrin, which might be part of the reason why natalizumab is so effective for multiple sclerosis. Another drug that we talked about is fingolimod, which works by a completely different mechanism. Fingolimod works on the process of T cells getting in and out of lymph nodes. They use the high endothelial venules to get into the lymph nodes from the blood. That's shown at the upper center in the red box. But how do they get out again? Well, that's a complicated process. What you see here is a lymph node, is a big gray oval. And you can see the naive T cell coming in through the high endothelial venule at the left. And within the lymph node, that naive T cell may or may not find its antigen and be activated. The one at the upper part of the gray oval is the naive T cell that doesn't find antigen, and it will turn on a molecule called the S1P1 molecule, which is what senses S1P, sphingosine 1-phosphate, which is in high concentration in the blood and in the efferent lymph, but in very low concentration in the lymph node. So it will simply use that receptor to follow the efferent lymph right out of the lymph node. The activated cell will also turn on S1P1 when it comes time to leave the lymph node. It'll stay there for a while, as you see those three little balls at the lower center part of the lymph node. It will proliferate, it will get activated, and then it's time to go out into the tissue and do its job. So it will turn back on that S1P1 molecule that was turned off during the activation process, and it will also follow the S1P gradient out into blood or into lymph, blood, and then tissue. What fingolimod does is block that process. It knocks off that receptor, the S1P1 receptor, by stimulating it until it goes inside the cell and stays there. And so the cells are essentially locked up in the lymph node and not available for trafficking. And that's how fingolimod works. Interestingly, a group of investigators showed recently that interferon beta may work the same way, but it turns off S1P1 in a different fashion. The molecular mechanism is different, but the effect is the same. So all of these drugs target leukocyte and in particular lymphocyte trafficking as a key event in multiple sclerosis. Now let's get back to our patient who's waiting for us patiently and ask, what is causing her breakthrough disease? You remember that MRI brain scan showed new lesions after starting interferon beta. Now, one possibility is that she has developed neutralizing antibodies. Interferon beta is a protein, and 5 to 25% of patients, depending on who they are and what preparation they're using, will develop neutralizing antibodies that make the drug ineffective. This is not, however, the most common cause of failure of interferon treatment, and it probably wouldn't happen this quickly. It would be unusual. Another possibility is this is just the wrong medicine for her. For reasons that we do not understand, about 20% of relapsing remitting MS patients on interferon beta will show this early clinical or MRI breakthrough, meaning active disease with attacks or new MRI lesions, even without attacks, and they don't have neutralizing antibodies. If you leave these patients on interferon beta, their prognosis over the long term is rather poor. So what are our second-line drugs for multiple sclerosis? Well, they're some of the ones I talked to you about. Natalizumab, the alpha-4 integrin antibodies, fingolimod, the S1P receptor inhibitor, and mitoxantrone, a cytotoxic immunosuppressive. So let's move on then to decision-making. Our patient is waiting for us. Mitoxantrone is not appropriate for her. The toxicities are somewhat disturbing. There is a risk of treatment-associated leukemia, of cardiomyopathy, and there's also a risk to her fertility, which is important for this individual. So we're not going to use mitoxantrone. Natalizumab is effective in this setting and has been shown to be so in a large population of patients. It's been received by well over 100,000 patients since its release. However, natalizumab is complicated by a severe disease called progressive multifocal leukoencephalopathy, which is caused by reactivation of JC virus. It's called JC virus because it was named that before HIPAA regulations would have made that impossible. So it was actually named after the patient from whom it was isolated. So if a person has been infected with JC virus, they will make JC virus antibodies. This is about 55% of all the population. The virus infection is completely innocuous in everybody if it doesn't cause PML. But it does cause PML in about 1 in 1,000 people who are being treated with natalizumab. So it's a meaningful risk, particularly for a chronic treatment. And the risk mitigation approach now is to measure JC virus antibodies. If the antibodies are present, then you may want to think about another treatment. If the antibodies are absent, then natalizumab is a very good alternative. Finally, fingolimod is also effective in this setting. It is complicated by disseminated herpes infections, and in particular by herpes zoster. So the approach for risk mitigation for treating with fingolimod is to measure VZV, chickenpox virus, antibodies. And if they are negative and you really want to go with fingolimod, then you should consider immunization to establish VZV immunity before giving fingolimod. So that's our MS story. Now let's look at the rest of the body. We mentioned before that T cells receive a huge amount of information from the dendritic cells that stimulate them with antigen. You remember? They are stimulated with antigen, they survive, and they also differentiate. And in that differentiation process, they are told what type of infection this is. Is it bacteria, virus, fungus, or worm? And where does it come from? Does it come from the skin? Does it come from the gut, or two big exposed surfaces? Or does it come from somewhere else? Part of this information is delivered by the environment in the lymph node. In gut lymph nodes, we have high concentrations of retinoic acid from vitamin A, which tends to polarize the T cell to go back to the gut and shut off the machinery that would take it to the skin. Exactly the opposite in the upper left in those green boxes. The skin-specific signal is vitamin D. You know that vitamin D achieves part of its biogenesis in the skin, and high levels of vitamin D in a lymph node will tend to polarize a T cell to go back to the skin. So finally, our T cells start as naive cells in the upper middle there, and they are educated either to become effectors that will go back to a tissue and fight infection, or memory cells, but they all have the same sort of machinery on their surface to get them where they need to go. If you look at the upper middle, the little squiggle on the left is a chemokine receptor. The thing at the top that looks like an antenna is the selectin, and the integrin is on the right, the two little stripes with a ball at the top. So with the right combination of selectins, chemokine receptors, and integrins, a T cell can become skin homing, gut homing, other tissue homing, and it can continue or not continue to be able to go back to lymph nodes. So those cells that can go to the gut will be candidates to cause IBD. The cells that go to the skin will be candidates to cause atopy and psoriasis. The cells that go to other tissues, including the lung, will be candidates for pulmonary fibrosis and rheumatoid arthritis, and so on. So with specific trafficking interventions, we expect to be able to address many of these diseases in a relatively non-toxic way in years to come. So in conclusion, T-cell trafficking is central for immune responses. Lymphocyte trafficking in particular is now the best validated treatment strategy for MS. T-cell trafficking is mechanistically decipherable. We can figure out which molecules get individual cells to individual tissues, and the molecules required for trafficking to different tissues are clearly different. So it is appropriate to target T-cell trafficking to treat inflammatory disease, and the specific targets and complications, of course, are going to differ among the varied diseases. So we have lots to learn, and I think lots to achieve in years to come through this approach. Thank you very much for your attention today.
Thank you, Dr. Ransohoff, for a wonderful presentation. I have heard you speak on many lectures multiple times before, and I must tell you that I always learn something new every time I hear you. Dr. Ransohoff has been able to take a case study and incorporate a wonderful synthesis of the concept of neuroinflammation and how it can be pertinent to other autoimmune diseases. We have learned the importance of T-cell trafficking, which is central to the immune response, and mechanistically that these molecules required for trafficking to different tissues are different. I hope you agree that appropriate targeting T-cell trafficking for treating inflammatory diseases may be helpful in many different organs, such as the lung for pulmonary fibrosis or the skin for psoriasis or the joints for rheumatoid arthritis. The specific targets and complications will, of course, differ among the various diseases, as we have seen here. And despite the story of the naturalizumab as well as fingolimide, there are potential future agents that will also play an important role in treatment. And of course, above all, decision-making and risk mitigation of these variety of treatment regimens in autoimmune diseases that we all see will need further discussion and research. We look forward to having you join us in future RHR activities. Thank you.